A very warm welcome to all of our listeners joining us for this very special event hosted by Laureate International Universities in celebration of World Health Day. Let me introduce myself. My name is Pearl and I'll be the moderator for this webinar. It's amazing to see listeners joining us from all over the world, including South Africa, Palestine, United Arab Emirates, Singapore, Canada, Nigeria, and more countries around the world. So a very, very warm welcome to you all. Due to a busy schedule, it's worth noting that we will be limited in taking questions from the floor, but we do have advisors on standby who are able to assist you if need be. So World Health Day is held on the 7th of April every year to mark the founding of the World Health Organization. And it's seen as an opportunity to draw worldwide attention to the importance of global health each year. Over the years, World Health Day has had different themes and focuses ranging from the effects of aging population and the contribution of high blood pressure on the burden of heart disease. In today's special feature webinar, our guest panelists will be discussing two of the biggest issues facing the global population: the rise of vector-borne diseases and antimicrobial resistance. So I'd now like to take a moment to introduce our very special guest speakers. Our first speaker is Dr. Ibrahim Bello, and he's joining us from Nigeria. So a warm welcome to you, Ibrahim.
Yeah, thank you.
So Dr. Ibrahim Bello is a recent University of Liverpool Online Master of Public Health graduate. He will be talking to us today about the burden of malaria in Nigeria. So we're very much looking forward to that, Ibrahim. Our second guest speaker is joining us from Peru and is Dr. Amy Ferraro. So welcome, Amy. Thanks for joining us today.
Thanks for having me.
So Dr. Amy Ferraro is a teaching faculty on the Walden MPH program, and she will be discussing the rise of dengue fever in the Americas. Our third and final speaker is Dr. Michael Hornsey, joining us from the UK. So welcome, Michael. Thank you for joining us.
My pleasure. Thank you for having me.
And Michael is a senior University of Roehampton teaching faculty, and he will be providing us insight into the increasing danger of antimicrobial resistance. So I'm looking forward to this event. I hope all our listeners are too. And I'd like to now introduce properly our first speaker. So Dr. Ibrahim Bello, can you begin by giving our listeners a quick introduction of who you are and what you do?
Yeah. I'm Ibrahim Bello. I'm a medical doctor by training. In addition, I had a fellowship in family medicine, and I've completed the PhD, the MPH program of University of Liverpool. I lived and worked in Ile-Ife, southwestern part of Nigeria, as a medical practitioner. But in addition, I'm also teacher of doctors, and I'm involved in malaria control program.
Wonderful, Ibrahim, and a very warm welcome, and thank you so much for joining us today. So, Ibrahim, can you start by telling us about the impact of malaria in Nigeria?
Yes, Nigeria is the most populous country in Africa, and it has the greatest burden of malaria in the world, and has also recorded the highest number of deaths from malaria than any other country in the world. Nigeria has 25% of world burden disease of malaria, and out of the 160 million population, 97% of this are at risk of contacting malaria. In the General Outpatient Department, GP practice in Nigeria, 60% of patients seen by GP are malaria patients, and of the hospital admission, 30% of which is accounted for by malaria. And Nigeria recorded nothing less than 100 million malaria cases in a year, and over 300,000 deaths, and that's much more than deaths from HIV/AIDS. And of this, 11% are accounted for by maternal mortality. So it's a huge burden of public health as far as public health is concerned.
So you're really finding that Nigeria is very highly impacted by malaria. And we see a map here which shows how the malaria prevalence in children from 6 to 59 months. So why is malaria more prevalent in children in the southwest, north central and northwest regions, Ibrahim?
Yes, though Nigeria, I mean, malaria is endemic in all geopolitical zones in Nigeria. But the differences that you are seeing in Nigeria, in Nigerian map, which shows a higher prevalence of malaria in children in the northwest, north central, is due to the scale of preventive programs. Statistics have shown more household ownership of insecticide-treated bed nets in northeast, particularly in the southeast and south-south. So that is what accounted for the high prevalence in the northwest, north central, and southwest. Yeah.
And what are you finding are the major impediments to malaria prevention and eradication in Nigeria?
Yeah, the major problem, the underlying factor is poverty. Nigeria has one of the poorest people in the world. 65% by World Bank standard 65% of Nigeria actually below the poverty line. So that's a huge population. And, it means that for women, children, and adults affected by malaria, the affordability of the drug recommended as a medicine-based combination is quite difficult for them. So many go for counterfeit drugs, leading to increasing burden of malaria, leading to persistent parasitemia of malaria in the body and worsening cases of malaria. So it's poverty that is the major problem, and it affects also the funding of malaria control program by household and by community.
Thanks, Ibrahim. And so you studied the Master in Public Health program, and you noticed a change in the way you were approaching malaria prevention after studying this program. So can you explain to us the change in approach you've made since 2012?
Yes. Prior to commencing the online program with University of Liverpool, I worked along with my colleague in the hospital, and we wait what we see every day are patients developing malaria in their home and coming to the hospital. So we treat them. We treat them as they present in the hospital. So it's really, we treat acute cases. So what we did, and not only that, even in the pediatrics ward, and in the pediatric clinic of our hospital, children are always presenting with complications as a result of malaria. So what we did was a complete paradigm change based on the Foucauldian gate. We kind of stop confining our search for malaria parasites in the hospital, and then we move the scale of our preventive program to right to the home where these patients live. So that's exactly what we do. From the hospital, we take the fight against malaria to right into the heart of the community where people live and work.
And so why did you feel it was important to make this change in approach from, staying in the hospital to going out into your community?
Yes, I was born in Nigeria, and I was trained there and I've been working there. It's quite obvious that there's no amount of money, no amount of drug, and no amount of blood that can save, will be sufficient to combat malaria disease. So there's need for reorientation of practice. I realized from the University of Liverpool that there's need to invest in malaria control, in prevention of this disease, rather than thinking all our efforts in curing acute cases.
And so, Ibrahim, there are a number of ways you've tried to reduce the impact of malaria in Ife. So can you tell us about these approaches that you've taken?
Yes, this is a knowledge-guided approach, carrying out a preventive program and using the structure, which we learned from University of Liverpool. The first thing realized is I need to build an advocacy team, and it has to cut across. It has to cut across board: doctors, nurses, laboratory scientists, and other stakeholders within the system where I worked. So I have to exhibit a leadership quality in building up a healthy team, and I have to share this idea with them. And with that, we were able to map out our strategy. Which include health education of the community. Also, it involves, we found out that what has been found to have been winning the battle is vector control. So we go for the long-lasting insecticide-treated bed net by collaborating with WHO, drug company. We try to get the insecticide-treated bed net to the poor people that cannot afford this thing. And not only that, we embark on screening the population with the latest kit. Recommended by WHO. That is the rapid diagnostic test kit. And we compare our findings with that of microscopy, and we found it wonderful. So with this, we're able to identify people who have the disease, and then we embark on massive treatment with ACT, artemisinin-based combination therapy. Yeah.
And so health education is one of the big focuses for the advocacy team that you were talking about there. Can you tell us more about how you went about educating your community?
Yeah, we know, health education helps empower the community. Ignorance has been found to be a major impediment to the successful eradication of malaria in Nigeria. So we, using the guided approach from the University of Liverpool, I employed the media, which is available, accessible, and affordable. We did market sensitization, so we carried programs to the market. We educate the people on symptoms, signs, and complications of malaria and how to go about it. We also mobilize them to come for our programs. Then we use the live radio program. Using the mobile technology now enables even the poorest people to listen to the radio. So we make use of this opportunity. This tool. Then we know the culture is very vital in any successful preventive program, and there is the old way, we call it the town crier, which the traditional Ebola used to communicate with the populace. And so we prepared a car, we call it malaria car, and then we try to reach the people wherever they congregated in all the nooks and corners of the town to drive our gospel of the possibility of malaria eradication and the strategies that we can go about it. Not only that, we use the talking drum. That is most popular in the southwestern part of the country. It's a very effective tool to mobilize the people, to call their attention, and also to drive the message of what causes malaria, how it can be prevented, what they can do, what is possible. Yeah.
And so what do you feel was the most successful approach in terms of the health education programs that you implemented there?
Yes, health education about malaria, prevention is not so. It's not something new. But what happens at Novella put understanding the cultural, adding to it the cultural perspective and cheap technology that can reach the people, whether in the farm, whether at home, and anywhere they may be. So the populace do not, so they don't understand the relationship between Anopheles mosquito, malaria parasite, and symptoms and signs of malaria, and why they are spending so much money on facing the complications. So we find the live radio program very effective too. We can communicate with them in the language, the local language which we understand. We probably go ahead, we use the television as well. But what I found very convincing is the radio. It doesn't cost them anything as well. The talking drug and the use of the malaria card.
And so, what are the main lessons that you've learned from implementing these kind of approaches to dealing with malaria in your community?
Yes, the greatest lesson learned is the fact that teamwork is vital to any successful preventive program, particularly malaria. If an individual cannot do it alone, if not even community they can't do it alone. There is need for a healthy team. So there is need for shared understanding. But not only that, time is very precious. If you have not started 2011, I don't know how many people will have died from malaria by now. So many lives we were able to save just because we know what we want to do. We know how to go about it based on knowledge guided approach. We're able to we're able to design our program, map out the timeline, and then we hit our target. Also, the mobile technology, is very simple. You don't need to be able to read and write much to be able to access listening to radio or be able to reach us. So it's very, very effective tool. And also the fact that ignorance, is the greatest disease and is the greatest impediment to malaria in Nigeria. So we are able to convince the populace on the need to destroy the home base of the vector, which is nurturing, which is producing the malaria parasite.
Thanks, Ibrahim. And from your perspective, what do you believe needs to happen in the future to eradicate malaria within Nigeria?
Yeah, I'm convinced that it's possible for, I believe in the future of malaria-free Nigeria. It's that if there is the will, there is always the way. So the commitment and cooperation of every Nigerian, I know, is very, very important. And that can only come where there is knowledge diffusion with the grassroots. Apart from that, we need to, there's need to create healthy city. And this will require a healthy government policy in designing the houses, in ensuring there is good drainage, because it is this accumulated funds and water that provide good habitat for mosquito to thrive, and mosquito is the vector for malaria parasite. I know we cannot underplay the role of the international bodies. They've been doing a lot, but those activities have to be synchronized. They have to be, they need to complement the local funding. What I mean is, there's need to continue to partner with WHO, the Department of International Development, DFID, United Kingdom, UNICEF, Global Fund, the American Presidential Initiative. There is need to partner with them, especially in the areas of emerging technology for malaria eradication. That is vaccination. Vaccine have been found to work. It has led to eradication of many diseases. it is also possible for malaria, and there is need for all types of our government to network and contribute to the existing effort aimed at development of a novel malaria vaccine. Well, I talk much about healthy community and healthy city. It is a phenomenon which I learned from Liverpool, and it changed my opinion. It changes my understanding of malaria forever. That we need to create a healthy city to destroy the habitat that is nurturing the sector, which is helping malaria to thrive. So it is quite possible.
Thank you so much, Dr. Ibrahim Bello. We really thank you for that insight there, for the, how you're looking at preventing malaria within your community, and it sounds like you're really doing amazing work. So thank you so much for sharing that story. Just stay on the line, and we will continue our conversation once all the speakers are finished. So thank you, Ibrahim.
Thank you.
So I'd now like to welcome our second speaker today, Dr. Amy Ferraro. Amy, can you begin by giving our listeners a quick introduction of who you are and what you do?
Sure. So I'm a faculty member in the School of Public Health at Walden University, as you mentioned. I have a master's in public health and epidemiology and a PhD in health sciences, and my specialization there was in medical anthropology. So in the past, before coming to Walden, I was a fellow through the Centers for Disease Control and Prevention in the United States, and I assisted with outbreak investigations in Pennsylvania. This work is what led me to my interest in infectious diseases like dengue, but now that I live in Peru, my focus has gone to a more international level.
Okay, great, Dr. Amy. So can you start by telling us what is dengue fever and where it originated from?
Yeah, well, dengue was previously known as break-bone fever due to the excruciating muscle and joint pain it inflicts. Dengue is caused by any of 4 related viruses or serotypes, and they've labeled them dengue 1 to 4, and they believe to have originated in monkeys in Africa. And dengue was a geographically isolated disease until about the mid-20th century, when the first cases became known in Southeast Asia, and the first epidemics were documented in the 1950s in Philippines and Thailand. But it's believed that the Aedes mosquito, that is our vector for the dengue fever, it's believed that it was spread through World War II in cargo and troop movement, and now it's become a globally distributed disease.
And what is the global impact of dengue fever?
Well, dengue is currently the most rapidly spreading mosquito-borne viral disease in the world. There's about 2.5 billion people at risk for transmission of dengue fever, and that makes up about 40% of the world population. Dengue fever is endemic in 100 countries, and that might be on the rise. It's estimated that 50 to 100 million people are infected with dengue every year, and some estimates are higher due to unreported cases. Annually, there's about 550,000 cases of dengue hemorrhagic fever, which is the most serious form of dengue. And there's about 22,000 deaths per year, and most of those occur in children. So my opinion is dengue is a disease we should be paying more attention to.
Yeah, absolutely. With those numbers, they're very high. And so what causes dengue fever, therefore, to spread?
Okay, so dengue is transmitted by the mosquitoes Aedes aegypti and Aedes albopictus, and these are our vectors. The symptoms of infection occur about 4 to 7 days after a mosquito bite, and they last for 3 to 10 days. But it's only the female mosquitoes that bite, so she needs to feed on infected blood for a period of time, and then incubation occurs over the next few days, and then she can go and live for several weeks and transmit dengue by biting several people, or, depending until the point at which she dies. So the transmission cycle is human, mosquito, human, and that vector is critical. It's not that there's human-to-human transmission occurring.
Okay, and so why is dengue fever therefore most prevalent in Asia, the Caribbean, and Latin America?
Okay, well, the Aedes mosquitoes are endemic, which means they occur every year in the tropics and subtropics when rainfall is optimal for breeding. These climates are most prevalent around the equator, including some parts of Africa also has dengue, but mostly in Asia, Central America, South America, and the Caribbean have these kinds of subtropical and tropical climates. And so, but that's not without, there are cases sometimes occurring outside these regions because dengue is the leading cause of fever of travelers returning from those parts of the world. And so outside of these yellow highlighted areas, oftentimes we'll see some cases pop up.
And so in terms of the movement of dengue into the Americas, what has caused this movement?
Sure. Well, until the 1960s, dengue was largely controlled by massive DDT campaigns that killed the mosquitoes. And in this map, you can see that dengue was virtually non-existent prior to 1981 in the Americas. Overall, in general, global distribution of dengue can be attributed to rapid human population growth and increased urbanization. So these changes have led to things like substandard housing, inadequate water supply, and insufficient waste management systems, and these all in turn create an abundance of mosquito breeding sites. The problem is that anywhere that water collects, things like storage containers for drinking water, plant pot bases, gutters, tires, all of these can provide a habitat for the Aedes larvae, the little eggs. And so now dengue is spread through all of Central America and the Caribbean, as well as some parts of South America. In fact, Brazil leads the world for annual number of dengue cases among endemic countries, and between 2004 and 2010, they experienced 450,000 cases, a very large number.
Wow, that's incredible. Just in Brazil alone, that's amazing numbers. And so you can see here that it's also on the increase in the USA. So why is that? Why is dengue fever moving into the US?
It could be because the climate in regions coming up into the United States or outside of that subtropical zone it's extending. So while most cases in the continental U.S. have been acquired elsewhere by travelers and immigrants, in the last decade there have been outbreaks in South Florida, South Texas, and Hawaii. And these were not cases acquired elsewhere, so it seems that this region is becoming hospitable to the Aedes mosquito. Nonetheless, most cases of dengue fever in U.S. citizens are occurring in Puerto Rico, because the principal dengue vector, Aedes aegypti, is abundant year-round there. And in 2007, for example, there were 10,000 cases diagnosed in a major epidemic.
And so how can the spread of dengue be halted, and who's responsible for preventing the spread of this disease? Is it personal responsibility, or is it more of a governmental issue? What do you think?
That's a good question. In my opinion, I think everyone is responsible because elimination of the vector, the Aedes mosquito, is key to stopping the spread of dengue fever, and that takes both personal efforts and larger scale efforts. So on an individual level, it might be important for a person to protect themselves against mosquito bites, especially when they're in endemic areas. So this can be done in a number of ways. It can be done by limiting places where mosquitoes lay eggs. I already talked about getting rid of where water sits, securing screens on windows and doors, using repellent like DEET, but this should be done both indoors and out because the Aedes mosquitoes like living indoors. You can use by wearing long sleeves of pants, and these can also be saturated with repellent called permethrin. In some cases, you can use an air conditioner to keep out mosquitoes from the indoors, although this is obviously not possible in most parts, maybe not most parts, but where I live, we don't have air conditioning, and I know in a lot of parts of the world that's not common. And Dr. Abraham talked about the importance of using bed nets for malaria protection, but the Aedes mosquitoes actually like to bite during the daylight hours, so sleeping with bed nets isn't quite as important in stopping yourself from getting bit from this kind of mosquito. So that's mostly what can be done for the individual level. And then on a government level, it's important to clean up after storms, floods, and hurricanes because mosquitoes like wet places to lay their eggs, and it can take a large-scale effort to get rid of pools of water that accumulate after natural disasters.
And so how does global climate change have an impact on an increase on vector-borne diseases?
Yeah, I'm glad you asked this one because, in my opinion, it's one of the biggest reasons dengue fever may continue to spread. And this is for a number of reasons. Warmer and wetter conditions can increase the risk of infection for all vector-borne diseases, and here's why. Number one, warm weather increases the number of mosquitoes. 2, it causes female mosquitoes to bite more. 3, warmer winters enable mosquitoes to survive. 4, increased temperatures shorten the time for virus development. And lastly, higher humidity improves the survival of eggs. So global warming also enhances the frequency and intensity of extreme weather events. As mentioned previously, when there's natural disasters, they can create ideal conditions for breeding of mosquitoes. So more infected mosquitoes in areas where people have no immunity means more opportunity for dengue fever transmission.
And so you were mentioning a little bit about how we can protect ourselves personally, but are there any new developments in medicine that are helping to eradicate dengue fever, or is it just a personal level that we need to protect ourselves more?
Well, there's actually a number of new avenues for control, and the first one that's quite interesting is a vaccine that's been developed by Sanofi Pasteur. Stage 2 trials have confirmed that it provides protection from 3 of the 4 strains of dengue, and the Stage 3 trials are underway in Asia, Latin America, and the United States with about 40,000 subjects to make sure it's effective and causes no major adverse events. However, the fact that there was only partial protection from the vaccine requires more research. Why is this 4th strain not protected against? I'm not sure. But still, Sanofi Pasteur intends to mass produce the vaccine, and it should roll out next year in 2015. Another interesting development is a new CDC test. CDC was Centers for Disease Control in the United States, and it's been authorized for use in that country. It's a test that uses equipment and supplies that many public health laboratories already use to diagnose influenza. This is good because then there's no new infrastructure needed. And the test, it helps diagnose dengue within the first 7 days after symptoms appear, and this is when most people are likely to see a healthcare professional, and dengue is likely to be present in their blood. So when we can better diagnose and identify dengue cases, we can reduce the likelihood of mosquitoes feeding on their infected blood and further transmitting dengue virus to others in the household. A third method for control, which is noted in the top right of the slide, is use of geographic information systems for worldwide surveillance of dengue. And this particular program is called Dengue Map, and it's a system that overlays recent reports of local and imported cases from official newspaper and other media sources onto a global consensus map. This is slightly different because normally ministries of health just take their official reports that they gain from doctors notifying them, but this one can take some unofficial reports as well and maybe keep abreast of the disease in case it's spreading to new areas that we hadn't known previously. And then the last avenue for control I find quite innovative and perhaps the most promising for widespread eradication of dengue is called the Eliminate Dengue program. And the folks that are investigating whether Wolbachia, it's a bacteria that occurs naturally in up to 60% of all insect species, but is not in the dengue-carrying mosquito Aedes aegypti. They want to know if it can be used as an effective strategy to disrupt dengue transmission. So here's the schematic gets into how that might work. Basically, the genetically altered mosquitoes are released in the places where wild mosquitoes are prevalent. The Wolbachia mosquitoes breed with the wild mosquitoes, and then they pass on the bacteria to the next generation. So over the course of about 12 weeks, most of the mosquitoes will contain the Wolbachia bacteria. Now let's say one of these Wolbachia mosquito bites a dengue-infected person. When the mosquito ingests the blood with the virus, it's still a dengue-carrying mosquito. However, the Wolbachia blocks the dengue virus from working. So if that infected mosquito bites somebody else, then it doesn't pass on the dengue to that person. So in other words, the method doesn't necessarily kill the mosquito, it stops the dengue virus from being transmitted. And so this is believed to be a very low-cost, environmentally sensitive approach to dengue suppression and has lots of promise.
Yeah, that sounds really fascinating and so innovative in terms of finding a solution to this problem. And so in terms of, to wrap up, I mean, what do you believe needs to happen to eradicate dengue fever in the future?
Well, I believe a multifaceted global response is necessary to eradicate dengue fever, and it probably would affect other vector-borne diseases like malaria as well. So first of all, I think it's important to improve environmental monitoring of vectors. This includes mosquito trapping and use of GIS sensoring tools to monitor high-risk areas. This might take some new innovative technologies. Secondly, I believe developing better health surveillance is important, like programs like the Dengue Map, but also some scientists are arguing that dengue should be a notifiable disease like HIV and measles because that can help improve diagnosis and monitoring. It educates the doctors to be more aware of the symptoms, to report it, to pass the word on to the government offices so they're aware of how big the problem is as well. Third, it's important to improve mosquito control efforts. That's that individual effort to keep and clean and eliminate standing water out of your own homes, but also in the community in general, because spraying is just too costly and doesn't eliminate the Aedes mosquitoes from their home. So it'll take an individual effort to keep it out of your own house. Fourth, I think it's important to increase programs to create climate and disease-resilient homes and communities. This is something that Abraham talked about as well. We need dependable piped water systems, trash removal, and screened houses to remove contact with mosquitoes, but these kinds of efforts take money, and so large-scale investment by the government might be necessary. Number 5 might be educate and monitor travelers visiting endemic areas. So aside from the prevention efforts I already discussed, if you suspect you have a dengue infection while traveling, there would be something called a dengue triad of symptoms is important to note. Includes high fever, rash, and severe headache with bone, joint, and muscle pain. And if you suspect you have these issues, then you should see a doctor. And all travelers should be aware of this information. And lastly, I think that reducing global warming pollution is important because climate change may expand the geographic range of dengue's vectors, and addressing global warming at its source could help limit dengue and other vector-borne diseases.
Yeah, so it's really interesting that a number of things need to come together, and everyone needs to play their part there. So thank you so much, Amy, for sharing that insight into dengue fever there. We really appreciate it. And we'll come back to you in a little while to have a bit further discussion.
Okay, thanks very much.
So just before we begin Michael's the final talk today, we'd like to ask you, the listeners, to think about what you feel will be the greatest threat to human health in the future. So in the right-hand side of the screen, a poll question has now appeared. And we're asking you to think about, okay, what will be the greatest threat to human health in the future? Will it be HIV/AIDS, cancer, heart disease, climate change, vector-borne diseases, or antimicrobial resistance? So take a moment to think about that. That will be live for about 2 minutes, and then we'll come to these responses at the end of Michael's talk. So a warm welcome to Dr. Michael Hornsey, and thanks for joining us. Can you give us take us a moment to quickly introduce yourself and tell us who you are and what you do?
Sure. Well, thank you very much for having me. My name is Michael Hornsey, and I'm a senior lecturer at the University of Roehampton. Prior to that, I was a postdoctoral fellow at Queen Mary University of London, where we looked at not only the mechanisms of resistance to important nosocomial pathogens, that is to say bacteria that cause a particular problem in hospitals. We're also interested in the wider public health implications of drug-resistant bacteria beyond the fact that they're resistant to antimicrobial agents.
Thank you. And can you start by giving us an introduction into what actually is antimicrobial resistance? And this was a feature actually of the 2011 World Health Day. So can you tell us a little bit more about it and what people need to be a bit more aware of?
Sure. Well, resistance on a drug combination basis is technically defined, but broadly speaking, it's a situation where an organism, example a bacterium, I'm a bacteriologist, so there's no bias, withstands exposure to an antimicrobial medicine to which it was initially susceptible. So when you use antimicrobial drugs, this applies enormous evolutionary pressure, resulting in the selection of resistant strains. This is compounded by the fact that certain bacteria are able to exchange genetic material with each other, and this can result in the transfer and further spread of resistant traits. So, over time, you erode the effectiveness of antimicrobial chemotherapy.
And how has antimicrobial resistance become such an issue in recent years?
Yeah, okay. So, antimicrobial resistance is not a new phenomenon. Most of the compounds in clinical use today are either natural compounds or chemical derivatives of parent compounds that were naturally derived. compounds. So these drugs that have been produced by microorganisms themselves in the evolutionary battle for survival in their own communities. The problem in clinical and veterinary medicine has been the widespread use and, I'm afraid, misuse of antibacterial drugs over many, many years. And for the reasons I've already given, this has eroded the antimicrobial armamentarium to such an extent that we are now increasingly faced with the prospect of untreatable infections with some organisms in some settings. So as I say, I'm particularly interested in those organisms that cause problems in hospital, but this is not just a hospital-related phenomenon. So we're increasingly seeing certain strains of certain organisms in the community that are multi-drug resistant. By that, we normally mean resistant to 3 or more classes of antimicrobial agents. Obviously, if there's an adequate infection control policies and procedures in healthcare institutions, then this can allow the spread of resistant organisms. And importantly, there are relatively few new antimicrobial compounds in the last stages of clinical development. So we don't have a constant supply of new drugs to rely on. So as we lose our frontline agents, we're increasingly looking at scenarios where, and in fact, it's being reported all over the world, where certain species, in particular, certain strains, are resistant to all clinically available antimicrobials.
And it's interesting to see here that only 5 antibiotics have been introduced since 1968. So why has there been less development of new antibiotics since that time?
Okay, yeah. So this is a major issue, and I think there are biological barriers and there are socioeconomic barriers. And the biological barriers are you can split bacteria broadly, speaking into 2 major groups, either gram-negative bacteria that I'm interested in, and the gram-positive bacteria. For gram-negative bacteria, they have an outer membrane which excludes a lot of the drugs that are active against gram-positive bacteria. So a lot of these drugs that you see at the more recent end of our timeline here are mostly active against gram-positive bacteria, but gram-negative bacteria pose more of a problem. It's also that pharmaceutical companies have really scaled back investment in research and development for looking for new anti-infective compounds in general, and this is because now really the financial returns on their investment, which are considerable, we're talking perhaps billions of dollars and 10 to 15 years from identification of lead compounds to marketing the drug. Compared to other types of medicines, they're just not economically viable.
So that's really interesting. And you and your team are actually working on some research that are hoping to bridge this development gap. So can you tell us a little bit more about what you're doing and how that works?
Yeah, so there's a number of approaches and a number of initiatives, global initiatives, to ensure that there are cheap and readily available antibiotics for the future. But as I said, unfortunately, the development pipeline is relatively dry, certainly with respect to gram-negative bacteria. So we're looking at ways to combine existing licensed drugs in ways, novel ways, and what we're hoping to do here is to expand their spectrum of action. So we're looking for what we term synergies. And now we would begin by looking purely in the lab, in a dish, and then we obviously want to move into a whole animal model, and the traditional jump is straight into a mammalian model, such as the mouse model. But, well, that's a very expensive study to do, and there are legitimate ethical concerns. And so really, you really want only the most effective and the most promising combinations of agents to move forward to mammalian studies. So we're interested in using invertebrates, particularly the larvae of the wax moth, to investigate the in vivo efficacy of not only combinations of existing licensed agents, but also novel antibacterials against these problematic gram-negative organisms. Now, we're interested in this particular model because they're feature tame, they're relatively simple organisms. Now, it can be argued that that's a double-edged sword. There are questions over, well, you know, they're not much like us, so to speak. So, are the data meaningful in terms of human infection? And that's still an unanswered question, really. We think increasingly so. But importantly, and unlike other invertebrate models, they can be incubated at 37 degrees. They have, you wouldn't know from looking at them, but they have a very well-developed mammalian-like innate defense system. So we can assess the impact of an immune response. And we're able to rescue these animals by administering antibiotics to them. And so we're hoping to really see this model as a bridge between lab-based work and animal mammalian work.
And so in terms of this fear of a post-antibiotic era, what do you feel are the future directions to avert this issue?
Okay, yeah. So antibiotics are seen culturally, I think, all over the world as being freely available and cheap. And that's right, that should be the case. But actually, I think we need to, if we're going to maintain the current development model, that is to say that businesses develop and take new drugs to market, then we have to reassess the true value of antibiotics for society. Moving on from the economic argument, we have to widen the search for really novel pharmacophores, really novel agents in nature. We've spent most of the last 40 or 50 years chemically tweaking existing compounds. We've had enormous success in doing so, but really we're repeating the same failed experiment. That is to say, every time we introduce a new class of antimicrobial agents into the market, we inevitably select for resistant strains. So we have to come up, I think, with unconventional approaches to controlling infection, perhaps that don't focus so much on killing the organism of interest or stopping it in tracks. Perhaps it's just good enough to switch off a so-called virulence factor, something that it's producing that's causing disease. Or there's also increasing interest in using immunomodulation, so that's enhancing various aspects of our own immune system, and then that takes away the selective pressure, so you don't select for resistant organisms in the same way.
Thank you, Michael. Thank you so much for that really interesting insight into the research that you're doing there, and I wish you all the best with that research, and I hope it develops in a really positive way. And
Thank you.
So just before Michael's talk there, we asked you a poll question. We asked you, what do you think will be the greatest threat to human health in the future? And the results are now live, so you can now see the results. And it's interesting, a very varied response. A lot of people saying climate change, well, actually the most at 24%, but also vector-borne diseases at 16%, antimicrobial resistance actually is very high. It's actually higher than climate change at 29. So really interesting mixed response. So Amy, can you give us your view? What do you think is going to be the greatest threat to human health in the future?
Yeah, maybe no surprise because I talked about it several times in my talk, and it did come up on number 2 in the poll. I would say climate change is a really big issue and a threat to human health in the future for a number of reasons, more than what I've already mentioned. In my mind, climate change relates to so many health and social issues. So I've already talked about how it's related to vector borne diseases because it creates a better environment for the mosquitoes to breed. But climate change also affects clean air. That's linked to respiratory illnesses and asthma. Climate change will affect safe drinking water, and that's needed to prevent diarrheal diseases and maybe if there's no drinking water, just for life at all. It also affects sufficient food, so folks can avoid malnutrition. And it's implicated in secure shelter, which is critical to general survival. You know, I'm in Peru, and just a few days ago there was a huge earthquake in Chile. Now, this isn't necessarily related to climate change, but we're also dealing with something called El Nino here, which changes the temperatures in the oceans, and then it affects rainfall, and then there's flooding. I mean, entire towns go down mountains. But we're also seeing the climate in which mosquitoes can live is extending in the Andes Mountains. And so we're seeing spread of malaria and dengue up higher into the mountains than has ever existed before. So all these things are expected to worsen if we don't do something about greenhouse gas emissions. So I see these kinds of issues continuing into the 21st century unless we do something more serious about it.
Thanks, Amy. And Michael, do you agree with Amy, or do you think differently?
I do. I think, echoing Amy's comment, these actually, a lot of these answers they're intimately linked. As the climate changes, then infectious disease, this is in the focus here, inevitably becomes more of an issue. And that's not just for the tropical diseases, the vector-borne diseases, but also for organisms that are interested in. For example, we've seen studies done in Germany now where certain species of moths are beginning to infect hospitals because their ranges are being extended because it's simply getting warmer. And these are acting as mechanical vectors within these institutions to spread these multi-drug resistant bacteria from one patient to another. So I see these issues as intimately linked, and yes, climate change underpins all of these very important aspects.
Yeah, that's really interesting. And for you, Ibrahim, what do you feel is the greatest threat to human health from your perspective?
Yeah, based on what is happening here and now, there are a lot of funding in Nigeria and other African countries for HIV/AIDS and vector-borne diseases like malaria. So we have the prevalence rate really rising. So what is most likely to be the greatest problem that I see, imagine, is heart disease. Because we are not much talking about it, and there's a growing, there's a kind of burgeoning the middle class. And there's increasing obesity. So I see heart disease as a major problem, and non-communicable diseases in general. With cancer is among. We are not talking of cancer in Nigeria, not much in my own domain here. And we see people developing these conditions, presenting late, and the hospital in advanced form of it, and no one there's nothing much they are doing for them. So heart disease and other non-communicable diseases are starting to emerge. Well, climate change, I don't know. But I know we are just feeling slightly the impact. There's flooding. So it's definitely that problem looming in the sky in areas of non-communicable diseases.
Yeah, that's interesting. So you're really seeing the change in the types of issues that your community are having in Nigeria, changing from things like malaria to heart disease, and you see cancer emerging. So that's really interesting that you in the community are feeling very different things than maybe what we're looking at globally. So thank you all for those really interesting insights. And you know, as they all said, it seems to be not one thing that comes up, but climate change will have a big impact. So it's going to be interesting, and I hope all of you have found this an interesting and useful webinar to listen to. So I'd firstly like to thank all of our 3 guest speakers today for sharing their knowledge and their time with us. We really appreciate it, and we really appreciate you taking the time to speak to us today. So thank you all.
Thank you.
No problem.
Thank you.
So I would also like to thank you, our listeners. We appreciate you taking an hour out of your day to celebrate World Health Day with us. And if you have a question for one of our speakers regarding today's discussion, then you can contact them personally by email. You can see their email addresses there, so do reach out to them and say hello and ask your questions directly to them. But if you'd be interested in learning more about the online Master of Public Health programs or any other programs offered by the 3 institutions featured in this webinar today, then just let us know in the Q&A and we can connect you with a consultant. So thanks again, and we wish you a very pleasant end to your World Health Day. Thanks very much.
Thank you.
Thank you.